Hello everyone, welcome back to Hot Seat Season 3. I'm Omid Moghaddas joining you from Tehran. And once again, I'm so grateful to have the chance to share this educational platform with all my dear friends and guests who are exceptional educators from around the world, who I'm very grateful that they accepted to join us on this platform and share what they know, their knowledge, their skills, and their expertise with all of you today. And my dear guest is actually one of the, I think, most famous researchers these days. And if you are in the field of perio and implant, definitely at least you have read one of his articles because he's so good in that. And my dear guest today is Dr. Fernando Suarez. Hello, Fernando. Welcome to Hot Seat.
How are you? Hi.
Happy to have you, my friend. You know, thank you. Over the past seasons and sessions, even in Hot Seat Season 3, we decided and we tried to cover almost all aspects in implant dentistry, going in depth of the techniques in decision-making, how to increase our knowledge in our diagnosis and treatment planning, because every aspect plays an important role in the predictability of the treatment of our patient and for long-term stability. And today, the topic that Fernando got to talk about for us during the case presentation is actually one of the most interesting topics, and I think one of the demanding topics these days, which is on peri-implantitis, on treatment of peri-implantitis. And the focus today is going to be on resective therapy. I'm not going to talk about the details because I want to keep it a surprise for him, because I'm pretty sure you will get lots of knowledge out of his presentation. But before we start, I would like to have a short CV of Fernando for all of you. I'm pretty sure he's familiar to all of you. But as a tradition of Hot Seat, I would like to have his CV. And then we will go through the presentation, and for sure we will have a great discussion on the topic. Dr. Suarez Lopez earned his DDS in 2011 from the European University of Madrid. Shortly after, he moved to the United States to join the University of Michigan Periodontics and Oral Medicine Department, where he completed his master's and certificate program in periodontics. Before joining the University of Oklahoma as an assistant professor, Dr. Lopez held a position as an adjunct clinical assistant professor and research fellow at the University of Michigan Periodontics and Oral Medicine Department. He is also a diplomate of American Academy of Periodontology, an author and co-author of numerous peer-reviewed publications, contributing also to several book chapters, as well as international oral presentations. He's an active member of several professional societies related to periodontology and implant dentistry, and serves as a reviewer for multiple journals in areas of periodontics and implant dentistry. And as I heard from him, he will soon move to beautiful Spain. So for all of you interested, you can be in contact with him there also. So Fernando, we are ready for your beautiful presentation, my friend, and the platform is all yours.
Excellent. Well, thank you very much for the kind introduction, and thank you very much for inviting me to be here today. It's really a pleasure to be here and being able to share this presentation with you. Let me see if I can share the screen, and please feel free. Let me know if anything doesn't work during the presentation. Please let me know. We're gonna stop at any moment. Test one. Let me see. Should I share the desktop or only the Keynote?
Yeah, you can only the Keynote.
Let's go for the Keynote.
Yeah, perfect.
You seeing the presentation now?
Yeah, it's perfect.
Okay, excellent. Well, as I was saying, thank you very much for inviting me and for the introduction. It's really a pleasure to be here. I love these events and being able to share what we do and so on. I was very excited when you invited me to this presentation, because you gave me a chance to present something a little different than what I usually do. This is a presentation, as you said, that is mainly focused on a case. And there is a little bit of introduction about peri-implantitis and etiology and different treatment approaches that we have, but it's mostly about the case. And it was very exciting. It was very fun to do something a little different, because when I talk about this topic, I usually talk a little more about the prevention of peri-implantitis. I think peri-implantitis, as we will see during the case, sometimes there is really not an easy way of treating peri-implantitis. So I think at prevention, there's so much more that we can do to prevent these cases from happening. So when I talk about peri-implantitis, this is very often, this is one of my very first slides that I show. And what I talk here is that about the peri-implantitis, how we have the development phases of peri-implantitis when we start losing a little bit of bone. We have those components of, that we know of inflammation and exudate. And then over the last years, decades, we have focused a lot in this field and as far as like what happened once we treat peri-implantitis. Which one are the modalities that really work the best in the long term. And what I usually talked about is that it is quite the opposite that we should be putting the focus on, is that we should take a step back and think, why are we having so many cases of peri-implantitis to start with, and what are the factors that really play a role, so we can prevent this huge tsunami of cases of peri-implantitis. But today we are actually going to follow the arrow, and we are going to go all the way to the outcomes and see how we can treat it. So first, of course, we will start with peri-implantitis, and we will see what exactly are we talking about. What is this disease? So peri-implantitis, as we all know, it's a disease that we've been talking about for many years, for many decades now, and it has been defined in multiple articles back in the 1980s, 1994s, 2000s, and but lately, more recently, as we all know, the American Academy of Periodontology, along with the European Federation of Periodontology, they published this workshop in 2018 that they redefine what is peri-implantitis. And they said that peri-implantitis is a plaque-associated pathological condition that occurs on those tissues surrounding dental implants, and it's characterized by two main things. One of them being inflammation, obviously, of the surrounding peri-implant tissues, and progressive loss of supporting bone loss beyond what they define as physiological or normal bone loss after implant placement. So what are the clinical signs that we are looking for peri-implantitis? There is different thresholds that they suggest that can be used, and one of them being that in the absence of previous examination, if this is a case that we are seeing for the first time, and we don't really have clinical data, we don't have radiographs to follow up the case, what we should be looking at is whether or not there is bleeding, whether or not there is exudate, and then looking at probing depths at least of 6 millimeters and bone loss at least of 3 millimeters to where the bone is supposed to be for that particular implant. So without question, this is obviously a case of peri-implantitis. We can see many different factors playing a role. Obviously, it's not only the implants, and we can see several other issues, but we can see very deep probing depths, we can see bleeding on probing, and we can see exudate as well as the radiographic bone loss. So how often does it occur? Is peri-implantitis something that we should really be concerned about? Is this something, a couple isolated cases? Well, we know now very well, and this table could have been updated. There is many more research every year. We have new research, different type of research from retrospective studies, systematic reviews, meta-analysis, that they talk about the incidence of peri-implantitis. And when we put all together, we know that this is really something that we should be paying attention at, because the percentages, the prevalence is very high of peri-implantitis. We are looking more or less, and of course it changes depending on the article, and it changes a lot depending on what is the definition of peri-implantitis, what are the thresholds that you're using. But when we look at the data and all these papers together, we're more or less looking at a 40% prevalence of peri-implantitis at a patient level and about 20% at an implant level. That's very high. That's almost one out of 2 patients that have implants, they will have peri-implantitis. And now we go for what are the factors that cause peri-implantitis or play a role in peri-implantitis, in this inflammatory disease. And when we look at these factors, we realize that there is a great variety of factors playing a role in this disease. And here you'll see a list of factors playing a role, not only in peri-implantitis, but also in marginal bone loss. And I believe marginal bone loss is such a great component of peri-implantitis. Marginal bone loss, sometimes we see in research that people try to isolate marginal bone loss of peri-implantitis as 2 different factors. And I really believe these 2 go hand by hand. We can very well have a bit of marginal bone loss without peri-implantitis, but we cannot have peri-implantitis without marginal bone loss. So in my opinion, marginal bone loss is a key component. Those very first few millimeters of bone in our implants are key, are relevant, because if we don't lose those couple millimeters, we are not going to lose any more. To have peri-implantitis, to lose 5 millimeters of bone, we need to start by losing 1. So if we can prevent that first millimeter, it is really a key factor that we should be looking at. So you can see here, many different factors, from systemic factors, the local level, some more related with the prosthetic point of view, some related with the surgical point of view. So it can be a bit overwhelming. I can get a little tricky to really know what are the different factors playing a role in each one of those implants, because we need to look at them at individual level. But thankfully, in that same workshop in 2018, the American Academy of Periodontology and the European Federation of Periodontology, they did a great job summarizing what are the factors that we had the most research about. So what are the factors that we know about? And they conclude that there are two main factors that we should be really looking at. And the first factor is the history of periodontal disease, as well as poor plaque control and lack of maintenance care. These are the two main factors really playing a role in peri-implantitis. They also talk and discuss about two other factors that there is a little bit of controversy. There should be more research about, but I believe they do play a role, which are smoking and diabetes. And very interestingly, they identify a series of factors that they claim that there is more research, that they claim as areas of future research that we should know more, but there are different studies pointing out that they may have a relationship with peri-implantitis, which are the presence of keratinized tissue, excess cement, genetic factors, some prosthetic components, systemic factors, obviously other than diabetes and smoking, occlusion, and titanium particles. And when we look at all these factors together, we realize that there are many of those play a role. And for me, there is two of these factors that are very interesting that we have done with my friends and colleagues at the University of Michigan and several other universities in the United States and Spain. We have done quite a bit of research lately, specifically about titanium particles and the influence of different surfaces on peri-implantitis. And I believe these are topics that even though we don't have very solid evidence yet, I believe they do play a huge role in the incidence and the progression of peri-implantitis. And I believe in this year and the upcoming years, we're going to see more and more research talking about different implant surfaces and the presence of titanium particles, titanium debris, and so on. So now let's move to the actual topic of the presentation, which is the treatment of peri-implantitis. And as I said at the beginning, the first thing when we look at the treatment of peri-implantitis is take a step back and see what is causing that peri-implantitis. What are the different factors causing peri-implantitis? We know that there is a recurrence of peri-implantitis. There are cases that we may be able to treat successfully, but if we don't know what caused the problem to start with, we may fix the problem for a short period of time, but sooner or later it's going to come back if we don't change something, if we don't change what caused that peri-implantitis. So in my opinion, the very first thing that we should do that is often forgotten is to look at the etiology. What is playing a role in that case of peri-implantitis and fix that at a systemic level? Maybe patient education, maybe the prosthesis is not working so well, maybe oral hygiene is an issue, maybe the implant location is an issue, and then we shouldn't even be treating that case to start with. We should be removing those implants. But when we looked at the treatment of peri-implantitis, we find out that there is mainly two different approaches. We have the non-surgical therapy, and we have the surgical. And when we look at the surgical, there is different approaches that we have. We can always open a flap and access surgery just to clean it out. And this approach is often combined with either resective or regenerative. And we see lately that there is more and more these two approaches are used in these cases. We do a little bit of regeneration for the component, the intrabony component that we can regenerate, and we do more of a resective type of approach for the suprabony component, along with implantoplasty, trying to reduce those pockets, but at the same time regain a little bit of that attachment that we lost around the implant. And we have plenty of evidence to support all these different approaches. We have a lot of evidence from retrospective studies, case series. We have a lot of systematic reviews, some of which that we have contributed in the literature. And then we also have decision trees. And this is a decision tree that we published years ago at the University of Michigan that this may or may not be applicable at this time as we learn more of peri-implantitis, but we do have quite a bit of decision trees that telling us that what are some of the overall guidelines that we can use to treat these cases of peri-implantitis. But when we looked in the combination and all these different research and all these different publications on peri-implantitis, we realized that for the treatment of this disease, of this inflammatory disease, many of those papers, many of those articles, they seem to conclude something similar. And there is really no reliable evidence that suggests that a single approach is most effective. In other words, everything works or everything doesn't work, depending on the case, depending on, of course, on the surgical skills, and depending on many different factors, but everything seems to work if you use it in the right case. There is higher risk of bias. We find that a lot of these publications that we have on peri-implantitis, we don't have that many randomized controlled trials, and we have a lot of case series, retrospective studies, and there is always some conflict of interest here and there. So there is really a very, very high risk of bias, probably even more so on than with other fields in periodontics. They almost all conclude that further research is needed, which is a cliche. They all conclude that, but it's really, really true that we need to know more. And then we finally have decision trees, some of the ones that we have shown before. And now let's go and talk about the case that we were discussing about. And this is a case that we were talking a little bit before recording the presentation. As I was telling you, that when you first invited me and asked me to give a presentation about a case, the first thing that came to my mind is, let me just show something impressive. Let me show like a full mouth soft tissue grafting, or let me show a vertical bone regeneration, immediate implants. And then I kept thinking about it, and most of us have seen already a lot of very impressive cases, especially nowadays in social media. Everybody wants to show what they are capable of. And we have seen a lot of impressive cases. And I'm sure that some of the other speakers for this season of Hot Seat, they are going to show very impressive cases. But I wanted to show something different. I wanted to show something that it may not be that impressive. It is not, I don't think it's a bad case. I think it turned out well, but it definitely has some limitations. And one of the limitations are that this is actually one of my very first surgeries at the beginning of my residency, my first year of residency. And it was my very first case of peri-implantitis, of treating peri-implantitis. And I have actually never shown this case before. I have shown the before and after as an example, but I never shown the actual case. And I'm very excited for it. We can see that, of course, documentation could be a little better, and a couple of things that I would like to actually discuss with you and talk with you about this case, what could have been done differently. So this is a case that it's a patient, female, in her 60s, 70s, very, very nice lady, systemically healthy, as I remember correctly. And she came to the University of Michigan for just a periodic exam, periodontal evaluation. And she came, we started the exam, and then very soon after the exam, she was going to a different office for cleanings for the past few years after the implants were placed. And when she came to us, to the periodontics department and oral medicine at the University of Michigan, and she came, I was like, could you please remove your lower denture so I can take a look? And she was very surprised about that question. And I was like, why would you be surprised? I mean, it's pretty normal. I will consider. And she was like, oh, when I go for cleanings at that other place, they never asked me to remove my denture. I'm like, okay, that's very interesting. And this is actually what she told me. I'm not telling this to make the case interesting. She was very surprised because nobody never told her before to remove the denture. And of course, at that moment, we knew we have issues. Implants need to be clean, probably more than teeth. And this is what we found. And these are the very first photo that I took of her implants, the very first time that I saw her, the first radiographic documentation. And putting teeth aside, we did the cleaning, we did the exam, we realized that we have a big issue on the mandible on those implants. And this is the clinical presentation that we had at the very beginning, the first visit that I saw her. I got to know her pretty well, a very, very nice lady. We saw each other often over the next few years after I first saw her. But this is the periodontal charting that we found the first time that I saw her. As we can see, there is a couple of 4s on the left side, but on the right side actually. But as we can see, mostly 6s, 7s, even a couple 9s, 10s. Presence of bleeding on probing almost everywhere, and some aspects, some of those implants with exudate. So this is really a case that, without question, is a case of peri-implantitis. I don't think nobody will question that, whether or not this is. There's some people now debating whether some of the cases are physiological bone loss, which is questionable, or peri-implantitis. But I believe this is a case that there's no doubt that there is something wrong in this case. So this is the clinical presentation. This is the radiographic documentation, and then let's look at the options that we have to treat this case. When we look at this case, And we look at peri-implantitis in general. We have different approaches that we have. We can do nothing, just sit on the case, see what happened. We can do non-surgical therapy and see if that makes it a little better. Sometimes we do non-surgical therapy, just preparing the patient for the surgical phase of it. And then surgical phase. We have different approaches, but mainly we do both, either resective or regenerative or possibly combination. And then sometimes there is really no treatment possible. We need to extract those implants and start over or look for a different alternative. So let's look at the options in this particular case. What are the things that we could do? And we start with considering what can happen if we do nothing for this case. Obviously, if we do nothing on this case and we just sit and continue monitoring, or maybe like do even maintenance every 3 months or 4 months, whatever we can, peri-implantitis will continue progressing. And as we know, this is one of the papers published in this latest consensus that we were talking about, that peri-implantitis progresses over time in a non-linear accelerating pattern. So if we do nothing, this patient will end up losing those implants. It is not a question of if, it's a question of when are those implants going to be lost. So there is really not an option. So now the options that we have are non-surgical therapy, surgical therapy, or removing those implants and starting over. Let's look at non-surgical therapy. When we talk about non-surgical therapy for the treatment of peri-implantitis, we find that there is a great variability of tools that we can use. We can use all types of different tools, from ultrasonic, manual curettes, many different types of curettes, local chemotherapeutics, locally derived antibiotics, and we have many different tools that we can use. And this is a topic that we have researched, and we did a systematic review recently, a few years ago, and we were looking at non-surgical therapy, but not for the treatment of peri-implant mucositis, which seems to be pretty effective and is the treatment of choice for those cases. But we were looking at non-surgical therapy for the treatment of peri-implantitis, more advanced cases. And we realized that the conclusion is that non-surgical therapy for peri-implant mucositis, it is effective. It is actually the treatment of choice. But when we look at peri-implantitis, we do have modest and not predictable outcomes when we are treating peri-implantitis. And this review is already like possibly 3-4 years old. And I've seen very impressive cases lately in the literature about non-surgical treatment of peri-implantitis. And I believe it can be effective here and there, but it's really non-predictable. And many times, as I said, we do non-surgical therapy just to get the peri-implant tissues a little better, preparing them almost for the surgery. So when we look at this case and we look at the bone pattern and we look at the different factors, we realize that this is definitely not a good case, a good candidate for non-surgical therapy. So now we are we're left with 2 different approaches. Either we try to fix the issue or we remove the implants and start over. When we look at surgical therapy, we have these 2 main approaches, resective and regenerative approaches. And once again, recently, a few years ago, we looked at this topic along with our good friends and great clinician, Bahid Koskan. When we look at this approach, we realize that first of all, there is a great variability in the reported outcomes. And that great variability is caused by many different factors. Some of the most important are patient factors, different morphology, and what are the techniques that we use. But there is really a lack of evidence that support that reconstructive procedures are even better than resective therapy. I believe they can be so much better for specific cases and contain defects and so on. But when we look at the bigger picture, doesn't seem to be much more of a benefit when we look at many different cases together. And when we look at this particular case, as I saw on the radiographs and as I saw the clinical picture, we see that there is really no potential for regeneration. There is really nothing that we can do. There is very little, if any, intrabony component. And it's a case that regeneration would definitely not work. So we are basically left behind with 2 different approaches. We either try to fix this the best we can with resective therapy, and we remove these implants. So, and these are all what I consider reasonable approaches. And many times, what I do with these patients with periodontitis and peri-implantitis is that I inform the patients very well about what is happening and what are the different alternatives and what are the risks and benefits of both approaches. Because sometimes there is really not a right or wrong solution. I think both of these approaches would have been reasonable at this time. So we inform the patient, and this is a patient that I have had this experience like quite a few times. And these are patients that are a little older. These are patients that they probably have spent quite a bit of time and money to get to this point. to have those implants, and then all this maintenance throughout the years. And this is the patient that told me, this is it. These are the implants that I'm going to have. And once the implants are gone, I'm going to have a removable denture. I don't want more surgeries, and I'm done with this. So then, in my opinion, once a patient said that, I'm really more leaning towards try to save those implants as much as we can, because even though if we cannot save those implants forever, if we can give this patient another 10 years of enjoying those implants, those are 10 great years that she's going to have before she gets a removable denture. So then we realized that removing those implants is really not a good option for her for this specific scenario. So we go for resective therapy. We decided to do reduce pockets as much as we can, try to get a healthy or at least as stable as possible situation, and try to let this patient enjoy her implants for as long as possible. So we look at this case and we start to see some of the limitations that I was telling you about. As I said, one of my very first surgeries at all, and my first Peri-Implantitis case. And I had to admit that at that time, it almost seemed, not almost, it seemed like a little bit of an overwhelming case for me. It was a bigger surgery that I was used to. It was a little bit more bleeding than I was used to. Difficult to manage. Peri-Implantitis cases are not easy in general, and especially for somebody that is learning. But let's see what we have. So the first thing that we do is we open a flap. Opening a flap in these cases is challenging. There is a lot of inflammation. There is bleeding. Sometimes it's not hard to control, but it's hard to see. And what we do, this is a picture after opening, reflecting the flap and removing all that granulation tissue, inflammatory tissue that we see around the implants. And we can see those defects surrounding each one of those implants. We can see the very uneven bone morphology. We can see the implants exposed with multiple threads, especially the implant on the left side. So we open the flap, we clean to the best of our possibilities all that granulation tissue. And the next thing that we do is we do some mastectomy and osteoplasty. And as I said, forgive me for the picture, they can definitely be so much better. But we try to remove those intrabony components of the defects. We try to make it as smooth as possible. We are definitely not going to be able to have positive architecture, as we would like to have the bony peaks a little higher interproximally, but at least to have as flat as possible, something that can be maintained over time. And the other thing that we did that time was implantoplasty. You can see it look a little patchy, but we try to smooth those implants as much as possible, both the mini implants, the narrow implants, and the regular diameter implants. So I think I forgot to mention this at the beginning. I believe this patient, when she received those two normal diameter implants, they placed those three, I believe, immediately in the same surgery, aiming to have those implants as a temporary solution before the loading of the regular diameter implants. And for whatever reason, she ended up never having those implants removed. So she appears with 5 different implants. This is the photograph when we performed the implantoplasty. This is the closure. This is how we finished the surgery at that time. So we see the patient again. I think I saw the patient at 2 weeks. I couldn't find those photographs, but I have this photograph of 4 weeks follow-up. As we can see, quite a bit of plaque, quite a bit of build-up. Of course, the patient she probably has discomfort in that area. We probably asked her to take good care of that area and not be too aggressive with the brushing. So this is the situation after we clean it, and this is what we see a 4 weeks follow-up. We see that it's not pretty, but it's definitely looking better, looking more maintainable. And of course, a couple of things that we have to do, and we have to do this before the surgery, is patient education. As I was saying, I really take a lot of time and put a lot of effort into patient understanding what is happening. They need to know. We cannot do any periodontal or peri-implant treatment if patients don't know what is happening. They need to be involved in treatment, because otherwise we may be able to fix it for a short period of time, but if they don't know what is happening, it will sooner or later come back. Also, we need to establish, of course, a supportive periodontal therapy schedule for this patient. There are a lot of controversy. We have different publications here and there suggesting different timelines, different intervals for recall, but we established a 3-month recall for this patient. And also, we had to modify the prosthesis. This patient had the prosthesis for many, many years. It wasn't even adequately fitting anymore. And this is the prosthesis, how the patient came the very first time that we saw her. We can see she has those, from a blank, I forgot the name of those attachment. What was that?
The O-rings, right?
Correct. I'm looking for a different name, but yeah, it's obviously a removable prosthesis that she should be able to remove on a daily basis, and locators. That's the name that I'm looking for. Correct. So what we did, and this is how we delivered the prosthesis at the time of the surgery, with this a soft reline. We changed those attachments and we make it a little better cleansable, and we remove those big concavities that she has, so it could be a little better. And this prosthesis was, as she was healing, and during the next months and years, it was periodically adjusted to make it good for the fitting and make it good, easier for cleaning. And of course, as I said, over the next months and over the next year, it is extremely important that we establish a regular supportive perineal therapy schedule for the patient, with radiographs, with perineal charting, and of course, very frequent clinics, not only of the teeth, but also the implants. Here we can see a reevaluation of 15 months follow-up. One of the very good things about doing this case so early during my training in periodontics, and that I got to have a pretty long-term follow-up that is actually pretty rare during residency. We can see a much better situation. We can see that the bone level seems to be much more horizontal. The implants looking a little better. The soft tissue is definitely looking much better. But we can see, if we pay attention on the implant, on the regular diameter implant on the right side, the left side of the photo, the right side of the patient, we can see a little bit of exudate on that little line angle of the implant. And we can see that on the charting that most of the probing depths got much better. Quite a bit of an improvement, but we can see that 5 millimeters pocket and a little bit of bleeding and a little bit of exudate. And I remember this became somehow a recurrent issue, that specific site of the implant, and that is something that we treated again with non-surgical therapy, and with the locally delivery of antibiotics. And after a reinforcement of treatment on that implant, we eventually got it to have a stable and maintainable over time. And here we can see a comparison of before and after situation. We can see quite a bit of inflammation, redness, bleeding on probing, the uneven bone morphology, and we can see the follow-up. I believe this is the 15-month follow-up. We can see the changes radiographically. Still, the bone levels are not pretty horizontal, but what I consider quite a bit of an improvement from the first situation. And this is the 21 months follow-up. This is the very last time that I got to see this patient in residency. And this is how she looked. She was pretty happy with the outcomes. And the reason for that, even though it's a case that when you look at it, it may look pretty ugly, she was very well informed from the beginning, and she knew what the outcomes would be. So that's what is so critical. If you do this type of surgery, or somebody that doesn't know what they're going to end up with, they may be pretty upset. So these are the outcomes. And then one of my good friends, he stayed at the University of Michigan for a little longer, and he was able to show me this photo at a 6 years follow-up. I don't have a perineal charting at that time. I don't have photographs at that time, but from what I can see clinically, at least the implants were there 6 years later, which I believe, to start with, it's good for the patient. Obviously, it's good to know. And but I imagine, I don't know the probing depths, but I would hope that the probing depths are relatively stable. What are the things that we can talk about this a little more now? What are the things that could have gone a little differently, or the things that I could have done better, or the things that could have gone a little differently? First of all, soft tissue management. I believe some of these implants will have definitely benefit from soft tissue grafting at that time. We can see a complete lack of very limited keratinized tissue, very reduced vestibule depth. Which is very common. The patient barely have just basal bone. It wasn't any alveolar process. So soft tissue management could have definitely been improved. One of the things that I'm considering nowadays is our group have done some research with implantoplasty and the debridement of peri-implant particles and debris. And nowadays I'm questioning a lot the actual how useful it is to do peri-implantitis. Are we really getting more of a benefit, that we are really getting of a drawback from releasing that many particles to the peri-implant tissues? So this is something, not only for this case, I'm questioning just in general, and I still don't have a solid answer. That I'm very conflict myself. Sometimes I question, should I do it, should I not do it? Is there really a benefit compared to releasing all those particles? I'm really questioning that. And then the other thing is that certainly the 3 mini implants could have been removed. When I'm looking at this case, those are implants. I don't know how much. I wasn't that involved in the prosthetic part of the case. I was having a lot of help from a great faculty and great friend, Ivan Rudek. And I don't know how much benefit the patient really got from having those implants. They could have certainly be extracted. And that's something to consider. So when I look at this case, and the main conclusion, the main message that I wanted to deliver is that when we look at peri-implantitis, we have all seen a lot of beautiful cases, in presentations, in social media, regeneration of cases, implants that are almost lost and they just go back to being perfect. But peri-implantitis, many times, even we don't show it that much in social media meetings, peri-implantitis many times does not look pretty. And at least in my hands, I don't know how you can make out of that case a pretty case. This is a case that definitely has a lot of challenges. And this is a case that, in my opinion, there is only two ways to go, as we were talking before. You either remove the implants and start over with all the consequences, not only economically, like from the patient, from the morbidity point of view. I mean, maybe you can place short implants, or maybe you can do an all-on-4, maybe you can do all different approaches, but it is really not an easy case. Or if you want to fix the case, it looks like that. It is not a pretty case to look at, even though it has been stable. And as I said, the patient was very happy because he was very well informed. So we should be, it is great that we have these cases. It is great that many times we can fix implants to the point that they look like teeth in a perfect condition. But we have to be realistic, and other peri-implantitis many times does not look pretty. So that goes back to the key that I was telling you from the very beginning. It is, this case, in my opinion, it should have been prevented. This patient should not have gone those many years without maintenance to those implants, with nobody asking to remove that lower denture. And some of the other conclusions would be that we do have a very high prevalence of peri-implantitis, and the treatment not always work that great. Prevention, as I said, that's a key determinant for the long-term success. We should catch these cases very early. We take radiographs, we do periodontal charting. Once we lose that first millimeter of bone, do something. Don't let lose the next 2, 3, 4, 5 millimeters of bone. And finally, such a multifactorial approach. We cannot only treat the case and forget about the patient. There are many different factors. We need to know what are the factors playing a role in each specific case, and fix those factors. In this case, it was obviously the main factor was lack of hygiene and lack of maintenance for those implants. And with this, I wanted to thank you very much for your attention, and thank you again very much for inviting me. It's been such a pleasure to be here today. There you have my email. If any questions from anybody else, I'll be happy to respond.
Thank you so much, Fernando. It was actually what I predicted. It was very interesting topic to discuss, and I think it is really necessary to pay enough attention to such treatments in keeping implants sometimes, depending on our cases and on our patient demand, because sometimes it's in the aesthetic zone and the scenario is different, but sometimes we see that, as you beautifully showed and explained, we have the chance really to save the implant, and we need to look at the patient demand and how we can keep it going. And there are so many options like those that you showed that can help the patient. And maybe it's not really important to see 2 to 3 millimeters of recessions when it's not aesthetic and when the matter is the function of the patient, so why not? So I truly enjoyed it, and I really want to have a good discussion on this topic because it's actually one of my favorites to have it with you. You know, you can stop share if you want, because now
let me see how we can do that. Stop share. There we go.
Perfect. You know, Fernando, usually we see so many peri-implantitis cases. I can say maybe in posterior mandible, or sometimes in anterior mandible, the rate is higher. So many factors, as you said, can affect the outcome. Maybe at the time of implantation, there was not enough bone around the implant. The crestal part was thin or even dehisced. Tissue maybe was thin at the time, or no attached gingiva, semen retention, and so many other factors. But you know, when the patient comes, as you said, because your case was overdenture, but imagine if it was a fixed prosthesis like a bridge or a splinted implants. And we see the same scenario with so much bone loss. Usually in all literature, we see that if it's more than 50% of the implant length, the preference is to remove the implant, or if it's less than that, we try to save it either with resective surgeries or with regenerate, depending on the morphology of the defect. So I want to now know your experience, because you showed this case, and I have to say, truly, honestly, I had similar cases that when I talked to my patient, when I saw his or her demand and cooperation and with coming in for the maintenance therapy, we decided to do the implantoplasty, soft tissue graft, accepting the amount of recession that may happen afterward. So the patient have enough excess interproximally to just clean, and to keep that implant. So with that said, and with knowing the beautiful case that you showed, and with the old literature that we have, when the patient come with the same scenarios, what is your preference? The demand of the patient, or if it's more than 50% of implant length, you prefer to remove or redo the case?
Well, that's great question. Great question. And I don't think there is a simple answer to that. And I don't think I can tell you I prefer to remove the implants or I prefer to save the implant. It really changes case by case. As you were saying, many different factors playing a role. Many different factors playing a role. And I believe each case, same thing we have, many times we have this debate with teeth, with the same thing. Are we going to keep them or are we going to remove them? The problem that we have with implants, it's an additional problem, is that first, many times patients have spent so much money into getting to that place. They have gone through multiple surgeries. And many times we see these cases just a few years after the implants have been placed. So it is I believe it's a tougher conversation that many times around teeth, even though to start with, we should be saving as many teeth as possible. That being said, the 50%, I believe it changes quite a bit to start with. And I have done some of the decision trees saying myself that more than 50%, less than 50%. First of all, that put completely aside the preference of the patient. I believe the patient has a lot to say in these decisions. That's why I was telling you that patient has to be completely informed of the situation. And second of all, it changes a lot. 50%, is it 50% on a 6mm implant, or is it 50% on a 14mm implant?
Exactly.
So many different factors playing a role. And what I typically do, or not typically, what I always do is I inform the patients very well. I tell them what the numbers mean. I do little drawings for them. I say, this is where your gum tissue is, this is where your bone is, this is how long your implant is, this is what we're looking at. And then when patients know that, they're like, wow, this is really a bad situation. I'm like, yeah, it's really not looking good for you. And if I consider that there is two reasonable alternatives, we tell patients, these are the two reasonable alternatives. This is what we can do to try to save the implant. Many times with peri-implantitis, I do a little bit of a under-promise and over-deliver. I want patients to be aware that this is not looking good. And when I tell patients many times, it's like, you will likely end up losing these implants anyway. It's just a matter of when. Maybe we can give you 5 more years of implant or 10 more years of implant. So hopefully there are some of these cases that I can actually give them a lifelong implants. We don't know. But as far as extracting or keeping those implants, it changes a lot situation by situation. It changes if it is a fixed or removable prosthesis. It changes depending on the patient, depending on the expectation. As you were saying, this is a patient, is a lower overdenture in a relatively older patient. If you have this case in a 30-year-old maxilla, completely, you cannot do that for somebody. I mean, maybe somebody would accept that. Maybe somebody would say, you know what, I don't care, with very, very low smile line or something like that. But in that case, in my mouth, that case, maxilla, I wouldn't like to have that on my maxilla.
Yeah, and you know, speaking of implantoplasty, sometimes it's a matter of a case as a peri-implantitis that we want to clean the surface, we want to remove all the roughness of the surface and make sure at least it's going to be maintainable and cleansable. But sometimes, due to bad position of dental implants too far to the buccal, we face implant surface exposures, and we want to try to do like soft tissue grafts to cover the area. And we do the implantoplasty to make a smooth surface so that the connective tissue can be adhere better, and at least we reduce the prominency of that dehisced surface of the implant. So with that said, what is your, do you find any limitations or any risks in doing the implantoplasty? Me personally, as just an experience, I didn't find it risky. But as you also mentioned, and we have some articles available, there's a concern of those titanium particles to go through the tissue when we do the implantoplasty, no matter if we do the high volume suction or whatever. So what is your experience or thought on that?
So implantoplasty, I mean, first of all, we do have particles in almost every single case, with or without peri-implantitis, just for simply placing the implants and so on. So it's just a matter with particles, it's not as easy as whether or not you have particles, whether or not you're going to have problems. So it's quite a bit more complex situation. Depends a lot on the patient, depends a lot on the size of the particles, the concentration of those particles and so on. What happened with peri-implantitis is that we are really increasing that concentration of particles. We are really releasing a lot of particles that would otherwise not be there. So as far as doing implantoplasty cases with soft tissue dehiscences or very thin tissue that shows through and things like that, I don't do implantoplasty for those cases. I believe, as you said very, very well at the beginning, is like having very thin bone. Sometimes we place the implant and you do have bone on the buccal surface, but you know that bone will disappear. So, and this is a topic that my good friend Alberto Monge have researched quite a bit, that the soft tissues and the hard tissues surrounding dental implants, it's a key consideration. Now, implantoplasty for cases of peri-implantitis, as you said, I think it's predictable what we have. It's relatively easy to do. As far as the surface being smooth, it may look a little shiny for us. It may be a little easier for the patient to clean, but as far as smooth, bacteria can colonize the surface no matter what. I mean, microscopically, that would never be smooth. And I don't know the value. The more and more that I know about these titanium particles, the more that I read, the more that we research. I don't want to be paranoid about those things, but I really don't like them. I really don't like them. So I don't know. And nowadays, if I had that case, I'll probably do the same. But that's something that I didn't even consider years ago. I just do implantoplasty. I'm starting to be more and more concerned. I really don't like the issue that there are particles surrounding it.
So generally speaking, if we wanna decide for ourselves, if it's not from the patient point of view, or from the sensitivity of the patient, if some scenarios the same thing happens, the main preference for you is to explant that implant, redo the case, and be predictable as possible, right?
What do you mean? If I have a case like that in a different situation? Or?
No, I mean in a peri-implantitis cases with massive bone losses, and if we want to balance between the patient and us, and if we want to just choose the most predictable treatment for our patients, so the preference is to explant and redo the case, or even with knowing all these circumstances, you still prefer to try to save those implants?
As far as long-term predictability, great question. Once again, I don't know. I imagine.
The reason that I'm asking, Fernando, the reason that I'm asking that, because if you want to do the surgery on the case, no matter if it's regenerative or resective, the patient is paying some amount of money. He or she will be charged. And if you want to explant that implant, is also the same thing. But the only difference is that in the second scenario that we do the explant, the result's going to be much more predictable long term. But in the first case, it's really patient related, and follow-ups should be very strict, and even we have some question marks because case by case the scenario is going to be different. That was the question, indeed.
Yeah, so what is the more predictable? I don't know. It changes a lot depending on the case. For example, if the implants, one of the main things that we are looking at is what is the positioning of those implants. If the implants are not in the right positioning, if they're too far buccal or too close to each other, or very weird angulation, something like that, without a doubt, the most predictable thing is to start over. In the implants are in the right position. In a case like that, the case that I just saw, you could think what comes to my mind first is the most predictable way to remove the implant is start over. But then you think about start over. What are you going to do? Place extra short implants? Is that really more predictable than what we have? Cases like all-on-4 or things like that. You start like, I'm not saying all-on-4 doesn't work. It works or it doesn't work depending on the case. But what are you going to do? Vertical bone regeneration and start over? Is that really more predictable than treating that case of peri-implantitis? Just do a huge surgery, vertical bone regeneration everywhere on the mandible to now place those implants, to give another. Is that approach really more predictable than trying to fix those cases? I really don't know. I guess it goes case by case, but As far as ideally, what is most predictable? Yeah, start over. I have an implant that the raw surface is not exposed, that the soft tissues are the good quality soft tissues, that you have bones surrounding the implants. That is definitely the most predictable in the long term. But to get to that, is it predictable for us to get to that situation? Maybe not.
You're right. You're right. Absolutely right. And you know, in your case, on the left part of the patient, actually one of those temporary implants, it was interesting. The defect was like, first of all, it was circumferential and you had bone peaks. So after doing the implantoplasty, it was interesting for me because you had some, a little amount of contained defect that you had two options. Do a little bit of regeneration beside doing resective surgery. But what I noticed was that you remove those bony peaks and you make it flat, right? So I think that was a wise choice. And I want to know what came to your mind at that time doing that, anything behind it, or you just decide to do 100% resective?
So at that, and this is something many times when I'm treating peri-implantitis, I tell the patients we may or may not do regeneration, and I'm much more conservative from the opening flap point of view.
Yeah.
To see what you can do in case you could do regeneration. You don't want to start with a very resective approach and then realize that you wanted to do regeneration because now the soft tissue is an issue. For that case, from the very moment that I approached the case, I knew we were going to go for resective because in my opinion, once you have a case like that, maybe I could have gained 1 millimeter of bone, 2 millimeters of bone. What's different that's going to make?
Yeah.
It's going to make the surgery more complex. You're adding cost to the surgery. You're gaining bone not only in the temporary implant on that side, that is almost a useless implant. So for many different reasons, even best case scenario, let's say it may not have even worked, but let's say best case scenario, we do the regeneration part and it works, and you have 1.5 millimeters more of bone on that implant. So what?
Yeah,
exactly. So from the very moment that I approached the case, we told the patient, I told the patient, there is absolutely no chance we are regaining anything. We're just trying to keep what you have.
Yeah, that was, you know, I have to say that was a great message because, you know, usually there's a question that I ask all my guests during hot seat season 3. I want to ask you because it can be related to this case. And do you think with what we see every day on social media and sometimes on big podiums, do you think that sometimes we as practitioners are doing over treatments that are really not necessary for our patients? Do you agree with that?
To a certain extent, I do. I believe many times we treat patients because we want perfection. We want the cases to look the prettiest because we want a photo and we want this and we want that, but we want that perfection for ourselves, not for the patient.
Yes.
And that is something that I was very fortunate to have in Michigan, very, very good faculties. And one of them, Dr. Roger Hill, he really taught me a lot about this, to really like patient care and put your mind aside from what you want, from perfection, from this and that, and look at the patient, look what they need, look what they want. And that we don't need to, everything doesn't have to be perfect. And I do agree that many times we push the limits a little bit for us. And I try to not do that as much as I can. Sometimes there are some issues. If I see some issues, I point it out to the patients, but I try to be very, very honest and very open with them. And this is, if it doesn't bother you, if you didn't even know you had this, it is really nothing to be concerned about. Yeah, but that's a great question. I think nowadays, especially with social media, people are pushing a little bit the boundaries to go the extra mile, not for the patient, but for them.
Yeah, exactly. Actually, I'm really happy that I hear that also from you, because, you know, that's a question that I try to ask all the guests, because I think one of the realities, you know, perfection is good, but we need to know which patient is a candidate for that perfection. Most of the patients are looking for the treatment and they want to just have their comfort zone, and you know, they don't really care for a millimeter difference. And the point that you mentioned regarding that regeneration for 1 millimeter more bone gain really doesn't make any difference in the case. And as you said, I think even doing that, as also you mentioned, will make the surgery and even the outcome more complicated. And with that resective surgery, you gain the best result possible with great follow-ups. Fernando, I have to truly appreciate and thank you so much for accepting and joining. It was a pleasure for me. I'm pretty sure everybody have enjoyed your presentation, and really looking forward to see you in person very, very soon.
Yeah.
And thank you for your time, and hope you stay safe.
Well, thank you very, very much for the invitation. It was really a pleasure to present and to discuss with you. I'm looking forward to meet you in person, hopefully soon in the future. And thank you very much for everybody for listening.
Thank you so much. Take care, my friend. It was great talking with you.
Bye.